Okay. Hi, everyone. So welcome to our virtual Gastro SPR training day. My name is Stephen Fong. I'm one of the consultants at the Conquest Hospital, and I'm also joined by Dr. Mark Whitehead, who's also one of the consultants and nutrition lead over here. So I know you guys are having a difficult time with COVID, but obviously we've endeavored to try to keep this training day running so that you guys still have a delivery of education, because it is very easy to sacrifice that when things get quite tough. But you guys have to carry on developing your knowledge in different parts of the gastro curriculum. It's worth saying that now, if you got any audio or video issues, please unmute and let us know now. Because obviously I'm sharing my screen, but I won't be necessarily 100% aware if you're having issues. This is different for us as well. We did debate whether we could run this given the pressures, but I think by adapting and making some of the presentations virtual or pre-recorded, that's going to make things a bit easier. Now, the timetable for today is a bit flexible, but the overall plan is I'd like to try to see if we can get all the presentations done this morning. So we're truncating the SPR training day, so to allow you guys to get back to your wards or whatever you need to do as well. Roughly, the presentations will be 30 to 40 minutes, and so they've been carefully chosen in regards to nutritional topics. Mark is going to do gastrostomy care for the first 40 minutes or 30 minutes. And then after that, I have a few sessions that we've only just pre-recorded over yesterday about feeding disorders, particularly anorexia nervosa. We'll have some sessions about intestinal failure, and then also chronic intestinal dysmotility, looking at the latest BSG guidelines. So hopefully this will give you a decent flavor into the different areas. I mean, I've called the topic swimming at deep end, because some of these areas, particularly the feeding disorders and chronic intestinal dysmotilities, are difficult. You don't always have a good answer. So I think it's important to be aware of that sometimes in nutritional cases, they can be very complicated. So it's good to run through them with you guys. And, I want this, if possible, to be as interactive. So you don't necessarily have to ask questions through your microphone, but if you want to put it through the text messaging box, that's absolutely fine. What will happen after today, for most of you, if you're fairly tech savvy, you'll know that Microsoft Teams allows you to download the videos afterwards. For those of you who may be less comfortable with that, what I endeavor to do is to upload these videos to a specific YouTube website, which you can then access probably for the next month or so. Though I would say, as a suggestion, it might be worth you guys joining together to create your own Gastro SPR YouTube website, so that you can actually maybe have a database of all the videos covering the different areas of the curriculum, because that way all your colleagues can access them when they need to, and that's probably very good training for your SCE exam. A little message about things. I've learned a lot from my mistakes in nutrition. I think learning from mistakes is quite important. And the parts which I think I've probably underestimated is how important it is to understand nutritional physiology. What I mean by that is things like how electrolyte balances and shifts happen in the bowel, because a lot of that underpins the practicalities of using solutions such as St. Mark's. Having an organized system for nutritional assessment and management, which we will go through with today's presentations, but it's good to have a system rather than just doing things in a piecemeal fashion. And there's usually more than one solution to any nutritional problem. I mean, gastro is a lot about problem solving, but always try to think creatively and ask a friend or another specialist. Without further ado, we're going to pass it to Mark, but I've also listed a few reference websites that I think will be particularly useful for you guys for your SCE exam, particularly the St. Mark's Frontier webinar. That's free to register. And this one from Mount Sinai is very good as well. Mark, if you want, I think we can start with your presentation on gastrostomy care. So I guess all we need to do is, if you want to share your screen now, and we can try to get started.
Hello, good morning, everybody. I'm just trying to load the talk. As Stephen says, I'm Dr. Mark Whitehead. I'm nutritional lead for the Conquest, and going to just talk about nitty gritty of gastrostomy. And as Stephen said, please don't hesitate to interrupt. I want to talk a little bit the basic nuts and bolts about inserting tubes, what tubes we can use, and then problems that we quite often see. And as Stephen said, it can be really sometimes very, very complex. Nutritional decision making about what the right thing to do is, we have technology, but sometimes the technology isn't the right thing. Now, on better times, you would have been here. This is Conquest Hospital with our nice lagoon at the back. Today it's grey and drizzly and horrid. So nutritional support obviously is incredibly important. And as this slide shows, lots of reasons, times, place when we need to think about it: inadequate food intake, weight loss, and the weight loss we always say is greater than 10% of the body weight, which if someone is very obese, it can be quite difficult to pick that up. If somebody has swallowing problems or has been nil by mouth, we need to think early about nutrition. And obviously we can provide nutritional support both normally and artificially, a number of ways. Obviously oral supplementation is best, but other tubes, nasogastric, nasovaginal, and the ostomies, gastrostomy and jejunostomy. I'm going to talk a little bit about jejunostomy, but not much. And then obviously then there's parenteral feeding, which I'm not talking about today, but could do another time if wanted. So obviously tubes are inserted for lots of reasons. The main cause is CVAs. At the Conquest, we don't actually do many for strokes because the stroke unit is at Eastbourne. So we do a lot more for more complex neurological conditions, motor neurone and Parkinson's and head trauma. Increasingly more is being used for disability as well. I don't know if you found or seen, but the numbers of gastrostomies being used is decreasing. Even before COVID, we used to be across the trust inserting 40 a year, but more recently it's about 20 across the trust, although before COVID there was in just under double figures, so 11 2020. That is probably because I was worried to begin with, we weren't feeding people, but there's more people are being given an at-risk feeding than used to be. And the other main problem we have, and I'm sure you've seen a lot of this, is when gastrostomy falls out, a peg comes out, patient comes to AAU or the admissions unit, it's not reinserted or balloon replacement isn't reinserted, so the patients then come in, and it does take a few days at least to organise for a peg. So, we do waste a lot of bed days because of it. So optimal care is really important. So this is all very obvious, but if no tube, no calories, and you have risk of weight loss, using more complex alternatives like PPN while you're waiting, and with that then also going to be the risk of refeeding, which is a real risk that we have. So types of tubes, you know all of this, PEG, rigs, and the balloon replacement gastrostomies. A few surgical ones used. I haven't seen one put in here for many years now. There's all sorts of other acronyms as well, PIGS and LIGS, so per oral image guided gastrostomy, laparoscopic insertion of gastrostomy, laparoscopic assisted PEG. I don't know if you have, but I haven't used or seen those last ones. Now quickly, I'm just going to run through, I know you'll know this, but run through very quickly the PEG insertions. Obviously, patients are assessed for PEG. Here, until COVID, when things were rosier, I used to have a 1 peg slot every week, which I think is actually a very good way to run things. I would advise that for you when you have your service. So you have I did it on a Thursday, 1 slot on a Thursday. If there's a patient, get the peg done. If I do a nutrition round on a Wednesday, so if there's no outpatients, no person found on a Wednesday nutrition round, then you can use that slot for something else. Obviously, consent, you need consent, or form 4 if the person can't take informed consent. Check clotting, obviously important, platelets. I do an MRSA throat swab. Not everyone does it, but that is our guidelines here, just to decrease the risk of MRSA coming from the throat into the gastrostomy site. So as the silhouettes show, the endoscopy goes down, transillumination, finger pressing, C indentation. And I think that that's a secret of uneventful gastrostomy peg insertions, is that first bit. You need to really see a good tenting with the finger, and often move around the abdomen quite a bit to find the optimal site. Then local anaesthetic, and then we pass the cannula through into the stomach. You visualize that from inside. Grab the wire, just pass through the gastrostomy, pull that out, attach the peg, and push that, pull that out. So this is the pull technique. There is also a push technique which can be used where you use gastropexy sutures to attach the stomach as with a rig and then pass it. I don't use that. I know some people do. Does anybody else, any of you, has anyone seen the push technique for gastrostomies? If not, that's fine. And that's what it looks like from the outside. Next one's not a very good picture, but that's what you're looking for the inside. I like to have the flange fairly close to the gastric wall, not too tight, but tight, twist it and make sure that's all looking fine, which that one is. For radiologically inserted gastrostomies, the indications obviously are when you can't perform a peg either because it's contraindicated, or when the worrying problems like neurological problems where the respiratory effort is very poor, or you fail with endoscopy. Say surgically inserted gastrostomies are very, very rare. With the rigs here, what the interventional radiologists do is the day before have a NG passed, and then they put contrast, it's bariotrope they use, but contrast down the nasogastric tube, and then the following day do the procedure. And the reason for doing that is it picks up the transverse colon, so they can see when they're screening where the transverse colon is, because it's often really quite close. And I'm sure you've seen these, they use a push technique. So these are gastropexy sutures. So they have a titanium bar, the 3 of them here, which you push through abdominal wall into the stomach, and then when you pull back, it pivots on itself, and that approaches the gastric looming into the skin. I'm getting feedback now, which is a bit unpleasant. And then that's the tube going in. So the nursing care for the gastrostomy tubes: clean daily with the soapy water, rotate as well daily, 360 if possible, to prevent buried bumper, flush, and if it's blocked, you can try and unblock it. The peg tubes need replacing every 12 to 18 months, and balloon gastrostomies replaced every 3 to 6 months. Following peg insertions, I also have a peg clinic, so I do bring people back up to the clinic to check if there are any problems. I used not to do that because it can be, especially with stroke patients, quite difficult to get them back to clinic. But now doing most of my pegs for people with motor neuron disease, Parkinson's, they do tend to come up, and you do pick up problems early. Some of the problems I will we'll talk about a bit later, but so I think that's important as well. And then patients can talk to you about the tubes, the care of it, feeding, if there are any issues. I do it with a dietitian because there are various different ways that we can feed people, either boluses or with a pump. So we often do change things around a little bit. So gastrostomy tubes have been displaced less than 2 weeks after insertion. So what do we do then? Well, obviously we can't replace the tube because the tract will take at least 2 weeks to form. So you can't replace that, such as with a balloon replacement gastrostomy, until you tend to have to replace it with the same type of tube. Now, another learning point, which is quite important, we often get contacted to say from A&E, AU, it's a peg fallen out, it needs replacing. And then when you look into it a bit more, it wasn't a peg to begin with. It was perhaps a surgical jejunostomy or as a rig because a peg failed. So it is important to try and find out what the tube is, because I always get surprised how often people get that wrong. And then if a tube is displaced more than 6 weeks after insertion, then obviously we want to replace it as quickly as possible with a balloon replacement. And obviously we want the doctors to contact us as quickly as possible, try and replace it, even if it's a small Foley catheter, so we can keep that tract open. The patient doesn't need to come into hospital, and we don't have those many wasted bed days. As I said just a second ago, yeah, I don't mind for short-term Foley catheter if there's nothing else. A small one, a pediatric catheter often works very well, and these are just the BRGs or balloon replacement gastrostomy. This is a Mickey low profile device, very good because the flange is close to the skin and it doesn't get caught on clothing. And this is one with the more normal attachment for feed. Usually really easy to replace. And also very important with feeding, always ensure the patient is as upright as possible, 30 to 40% angle. If they're too low, they can get aspiration. And if recurrent aspiration happens, then we consider a jejunal extension of a peg. Oops, let's flip back. So you can, this is called a peg J, so a peg tube with a jejunal extension, which I'm sure you've all seen. The ordinary peg tube is here, and then you have an extension through it. Tends to be a 6 French extension that endoscopically you pass down, get it down as far as you can into the jejunum, if you can, at least past the ligament of Treitz. These are useful short term. They do tend to migrate back. That is one of the big problems. So the jejunal extension tends to come back. The connection between the jejunal extension and the peg bit, it's quite easy to pull that out. So patients or nursing staff quite often pull that out. They can be a bit fiddly to do endoscopically. They take quite a time often because you get the tube back down into the jejunum, and then as you pull the scope out, it tends to come back with it as well. You can clip them, but I don't tend to do that. If you get the position right, they tend to work okay. Is that a comment? I've got a comment there. Was that? Dominic says try and grasp if endoscopically and pull through. Okay. And so this is an X-ray of, well, they put contrast in as well, but an X-ray of the PEG tube with the jejunal extension. Jejunostomy, the percutaneous endoscopic jejunostomies, where you just go straight into the stomach, into the jejunum, directly in there with a push endoscope, get that down into the jejunum. Similar procedure, transillumination, indentation, pass the tube in, wire in, grab it and pull that back. They aren't easy. We do them, haven't done more than 5 in the last 10 years. The problem with them is that it actually can be really quite difficult to get the transillumination right. The jejunum tends to move about quite a bit. So what we tend to do is use a surgical jejunostomy. They use a mini laparotomy and get the tube as proximal as you can to maximize absorption. So again, do a couple of those a year, and there are people that have failed with PEGs, aspiration, the PEG-J hasn't worked, and mostly do very well. I've got 5 patients who are long-term with these and have done well. Now, just going to talk a little bit about problems that we can see. So it's quite common to get leakage around the stoma site, irritating liquid, either bile, acid. You need to check that the bolster is in the right position. So pull the tube back if you can. Assess the patient, see if you need a larger size tube, which you often do. So often do upsize those. Sometimes need a bit of a stretch or Seldinger technique to get the tube in. There's a new type of tube called the chrysalis, which has got a flat flange, flatter rather than the balloon replacement ones. The balloon obviously being round, the area in contact with the gastric wall is actually quite small. So we can try, I have tried those without, to be honest, a fantastic success rate, but upsizing the tube can be one of the best option. Occasionally you just need to replace the tube as well, so that does happen. Keep the area as clean as you can, use barrier cream, and I don't like using dressings on PEG sites, as I'm sure you all know. Try and keep them undressed if you possibly can, but if it's leaking badly, you have to do that, and so you have to put a dressing on. Tube blockage is very common, especially with when the tube's being used for medication. We do have a list of what drugs can go down the gastrostomy tube. It tends to be the slow release medication, the things with small granules, they tend to block it. Always flush the tube with water before and after drug or feed. If the tube becomes blocked, flush it. We can use clog zapper, but if the tube's been in for a long time and you can replace it, by a long time I mean more than the 6 weeks, you can then just put in a balloon replacement if it becomes blocked, if that's possible. And that's often the easiest thing to do, because once they start to block, that tends to carry on. Infection sites that around the site is quite common, so we need to swab, give antibiotics if need is there, and then obviously education, the site care, cleaning, washing hands, and again, dress if needed. Quite often you do get candida infection. Again, important learning point is infections often happen when the tube is getting a bit old. So always look at the tube, see if it's discolored, going brown, seeing if it's bobbly, which tends to mean it needs replacing, and do so if you have to. overgranulation we see, you used to see quite a bit, don't see it quite so often. So you can see the granulation around the site. Now again, this is, the cause is because that's an old tube. That tube needs replacing. You can use silver nitrate sticks. I have done that when nothing else is working. It's not very pleasant. It's uncomfortable. Both of the patients, I find it quite uncomfortable because you hear sort of the sizzling sound. Sorry, it's flicking backwards and forwards. But that can happen. But in this case, it was just needed to replace the tube and things were fine. Now, this is a bit of a horror story, and unfortunately, it was from this hospital a number of years ago now. It was somebody who had a surgically inserted tube, as you can see from the operation scar there. And they put a Foley catheter in, and then hadn't replaced it, and hadn't really informed anyone until this quite young chap came back in with an incredibly manky site and just needed replacing. Yes, Foley catheters can be used to keep a tract open, but never leave.
Oh, hi, Mark. I think your sound's come off for some reason. Do you want to check your connection? Mark, can you hear us? Hello? Mark, can you hear us? I think your speakers might be malfunctioning. Hi guys, I'll just check with Mark. As typical as with everything, sometimes it's a little bit of an IT glitch here. So just give me a second. I'll just check with him if it's just his connection. So just give me a couple of minutes. Hi Mark, I think we can hear you now. Hopefully, let's see. Can you hear
Can you
us?
hear me? Can you hear me?
Yes, we definitely can.
Sorry, I don't know what happened there.
That's okay. Typical IT. Do you want to share your screen again? Hopefully,
Yeah, I'm just starting that. Yeah.
Running. Brilliant.
I was talking about buried bumper.
Yes, that's right.
That's when it stopped working.
Yeah, I believe so. We had a picture of the bumper in the endoscopic picture. I think that's when the sound cut off.
I'm sorry about that, everybody. But so saying the thing with buried bumper, to prevent it, as I said a bit earlier, the most important thing is to rotate the peg regularly, to insert it if it's possible by a centimetre, and it stops it happening. If you don't do that, it tends to overgrowth like this, and we do see quite a few of these. So what we can do is replace it, put another tube in, cut the peg tube off at the skin and put another one in, and try and remove it endoscopically, which sometimes is possible. This is what it looks like on a scan. So obviously not in the lumen. And there's a new device called the flamingo device, which obviously is based because on board a flamingo, because it's like the shape of the flamingo's neck, which is like a sphincteratome, and it allows you to cauterize the buried bumper. So when you insert this, you do an endoscopy, have a look into the stomach, put a wire, if you possibly can, through the peg site, the peg lumen, and it goes into the stomach, and then cauterize. You can see here it's the flamingo bent back on itself. There is the cautery wire, and you just cauterize, and then allow that flange to be clear, and then you can pull that out with a snare or graspers, and then replace it. Best not to let it happen, obviously. The other thing, obviously, you can get is neuroperitoneum, chest X-ray, air under the diaphragm, and this was actually a replacement. It was done here, balloon replacement gastrostomy, and didn't go into the stomach, so caused a neuroperitoneum, which actually took the tube out, and the patient did settle. We've also, I haven't got a picture of it, I couldn't find it, but there are other issues that you can have. Not all that long ago, we had a patient who had a balloon replacement. He was 75-year-old, had a CVA, had a peg inserted elsewhere, had a few little grumbles over the year and a half with it. A couple of times had to come up to A&E, but came to have the peg replaced with a balloon gastrostomy. That was done, and as soon as feeding started, he began to pass the feed per rectum, and what had happened was that the initial peg tube had gone through the transverse colon into the stomach, and then when it was replaced, didn't go all the way through the tract, just when the balloon went into the lumen of the colon and caused the diarrhea. So it needed to take the tube out, and unfortunately the patient died following that, mainly he was quite unwell anyway, so it was just triggered that. So an important thing there was that he had talking to his family afterwards, he had some pain. As I said, had him come up to A&E, just crumbling pain. And if he'd have had a scan for that, we'd have picked that up, or even a tubogram might have picked it up. And that's one of the reasons that the radiologists, the IR consultants, put the barrier drop down, because you can see where the transverse colon is. Obviously, when we put the peg in, you do aspirate, looking for air when you've injected the local anaesthetic, but you still can miss that, and it's actually quite a common occurrence. Oh, that's following. That's just a picture just so that the flange can pass down into the bowel, usually pass through on their own, but can occasionally cause blockages. So I've got a few more minutes, but I'll just, the conclusions of the PEG bit. If the gastrostomy is dislodged, find out what the type is, as I said, and replace it, possibly with a balloon replacement gastrostomy, but if it was a rig and things are a problem, especially if a patient has got a severe disability and they need a enhanced sedation or general anaesthetic, then it's best to put something that's going to last as long as possible. Try and avoid those unnecessary inpatient bed stays, so get the tube replaced as quick as you can. And of that last patient I was talking about, if the gastrostomy has been inserted and there's pain, even mild pain, consider a CT scan, and we do have PEG passports. Now I've got a couple of brief cases, fairly straightforward, but so a 74-year-old man lives alone with his carers, got type 2 diabetes, renal failure, and now has had a CVA. He can't communicate, there's a feeling about aspiration. Nasogastric tube has failed, and so PPM was started and a gastrostomy was arranged. And it's always the problem, if a patient, say this patient was pulling at his tube, couldn't really communicate, but was pulling at his tube, it can be really difficult to know, is a patient withdrawing their consent? Are they just very confused and pulling it out? Do they want to have treatment? Are they refusing treatment? So I think it is best to check to see if there's advanced directives, what's best for the patient. The patient's right, and he needs to.
You've got a lot of static on your phone. I think the connection might be loose again or something.
I don't know. Okay, but so it can be really quite difficult to weigh what's in the patient's best interest, their mental capacity. Can they, do they have capacity? But it's important to give the patients the best treatment they possibly can. So with the Mental Capacity Act, assume capacity, and it's important to communicate those decisions. And the patient can make the wrong decision. You can think it's the wrong decision, but if they can, if they've got capacity, they do have the right to get things wrong. And it is important to communicate. And with difficult nutritional issues, it really is important to communicate with everybody, the patient, family, his carers or her carers, nursing staff on the ward, because there can be conflicts. People want different things. Quite often you have patients with one member of the family want something done, the rest of the family are really sure they don't want anything done, and you just have to steer that really quite tight path sometimes. And it is important to document decisions and also how they're done, have case discussions if needed. The second one is a 84-year-old with Parkinson's and Parkinson's dementia. The SALT team say he's had risk of aspiration, got a low BMI, and has been nil by mouth. Tried a nasogastric tube, he pulled it out, put in the bridle, still managed to pull the tube out, and again then need to meet with the family, decide what is best. Dementia can be an issue with feeding, nutrition, and I think it really is important not just to label people as being demented or not demented, and if they're demented, don't have a tube. It's important to know what stage of the dementia they are, how well they're living, because quite a few people with dementia do live a fairly quality life. Not too long ago, I was actually asked to go to another hospital because there was a patient who had had dementia, and so endoscopy and PEG was turned down. But the family were really unhappy about that, so they asked for about a third opinion. And The facts were that yes, the woman was demented, but she had a stroke, and so it probably was reversible. And she had a fairly good quality of life. She lived in a nursing home. She read the papers and discussed the papers with her family. Yes, had dementia, but not end-stage dementia. So a feeding tube was put in, and she did really well. So I think you do have to be careful, take each patient as they come, take them differently, and communicate. So I know you all know about the Burke case with the Court of Appeal about the right to treatment. Whether, I mean, the right to refuse a treatment is not the same as demanding a treatment, and a patient can't demand treatment which a doctor thinks is not indicated. The final couple of slides, it's not only humans that have the pegs, and being in Hastings, everything's about the battle. So even our concreter is called William the Concreter. So thank you very much. Have anyone got any questions?
Mark, thanks so much for that. I think that was really great introduction to gastrostomy care. I think some of the take-home messages I've got from that is you definitely need to do your homework. You need to know exactly what tubes the patients have had, isn't it? I think that's one big problem we have is people just say patients come in, pulled out the peg tube. They don't get any idea about the sizing, the French size, whether it's a Corflow or is it a different kind of brand. Is it a balloon replacement or is it actually a previous peg? So all these change your management plan. I think one message for registrars is when you get that referral from A&E about the peg, try to see if you can get as much information about the actual tube. Sometimes even better if you go there yourself to see, because a lot of the patients might actually come in with the tube that came out. So definitely have a look at it rather than make an assumption.
Yes, and that's why lots of hospitals now are having passports, you know, peg passports, rig passports. Ours, we have it. It's not working fantastically, and it doesn't tend to be the rigs that have them. But so a patient has a document with them to tell you who's looking after them, what it was, when it was put in, when it needs to be replaced, without having to go through the notes, which it can be really difficult to find the notes. Even, you know, I know I've been here a number of years, so I know the way the system works. Someone in A&E may not. So finding out whether it was a rig or a peg, you often have to go into the radiology reports, and because it hasn't been put in any other note. So.
Rachel's got a question, which is, I think, really helpful. If you put in a balloon replacement, how do you decide which connector you send them home with? Is it simply to do with the size? I mean, personally, I think the answer to that, there's a lot of factors here. It depends on the actual brand of the tube and what they came in with. And I think for me, one of the learning points is you need to familiarize yourself with the different connectors for the different tubes. Mark,
yeah, I think one of the, because I showed the sort of the low profile Mickey balloon replacement, which are great. The problem is that you need to have, or someone needs to have, a lot of manual dexterity. They're a push and twist, and they can be quite fiddly. So a lot of elderly people just can't use them. So I tend to use those for young people, or, you know, we do put quite a few pegs in very young people, and whose families can help them. So if somebody is a bit old, frail, arthritic hands, or, you know, relatives have bad eyesight, I tend to just use the normal one with the two attachments, one to fill the balloon and one for the feed, because most people find that easier.
And the connectors at the end of it, they can vary a lot depending, isn't it? So
they do vary an awful lot, and that is, again, can be a bit of an issue. And they can break, and then people do you know, DIY jobs on them. Quite often see things with tape around it, elastoplasts, you know, various bits of oxygen tubing in to keep it working. But yeah, those two main replacement ones, young people, the low profile Mickey, older people, your ordinary ones with the two connectors.
I think one kind of lesson I learned, especially for those of you who are kind of new registrars, is most endoscopy units will have like a cabinet with replacement tubes and connectors. I recommend you actually go and have a look at that cabinet, familiarize yourself with the different connectors and PEG tubes, because that will improve your confidence about knowing which connectors should go to what tubes when you get a patient in A&E.
Yeah, if I was doing this talk, if we're doing lecture theatre, that's what I would have done. I was going to bring some down, but they don't really project very well. But yes, because there's so many different types. People use different types of the PEG. Some are traction removable, some aren't. Some you have to remove with endoscopy. So they're all different.
Okay. Dominic had a question. Yeah.
Is it appropriate to tell them tube comes out, they can put a catheter in cleanly and then bring the patient in? The answer should be yes, but it's no. And the reason is that I've thought and talked about this to nursing homes. I do talks to carers and nursing home. Well, it used to when it was good times, and they're very worried about it. If you've never done it before, they're worried it's going to go in the wrong place, and occasionally it can do. So I think it's best to, I know it's best, bring the patient up and get it replaced as quick as you can. I do talk to A&E staff and the AU staff, give them a quicker talk about how to replace things, so they will do it. Thank you.
Yeah, I think that's a tricky one. I mean, it depends on the care home or nursing home competencies, isn't it?
Yeah. I mean, some carers will do it because they're used to it. So it does. I've got patients that when that happens, they pop it in. But most carers and nursing homes won't.
I think if they're used to it and they know what they're doing, that makes sense. If not, you've got a bit of a race against time for the next 2 to 4 hours to try to get them up to hospital to get something in there to keep the tract open. And I've been lucky a few times when we just got it through. But you're right. If they're in after 6 to 8 hours after the tube came out, then chances are that tract has closed and you've lost.
Sometimes you can get tube in. I mean, sometimes quite a long time afterwards.
Yeah,
usually, but I always give it a go. It's always just don't assume it's not going to go. Give it a go.
Absolutely. Okay. Mark, thank you very much for that. We got one more from Dominic. A&E staff seem to be catheters in. Yeah.
The way to get past that is do lots of teaching sessions.
Yeah. I think when I was a registrar, I'd actually do a few sessions in A&E too, and I really think that's not a bad QI or leadership project for new, starting off reg, because it reduces the amount of hassle and work and unnecessary admissions for these patients. Because you have a patient, especially now with COVID times, having that patient in hospital purely for a PEG change because you couldn't get it in time is such a waste.
Oh, terrible! It's
If they pick up COVID, it's horrible. Because most of the guys are stroke and vulnerable. So really think about improving and educating your A&E frontline staff, and that can have a very big impact, a massive change to these patients, actually. Mark, thank you very much for that. I think that was a fantastic session.
I'm sorry about the sound from time to time.
That was very small, considering. Yeah, it was going to happen. So guys, I hope you've had a nice session here about gastrostomies. So this recording will come up onto a YouTube website later once I've downloaded and uploaded it. What I suggest, perhaps if you want, you can take a 5 or 2 minute breather, have a cup of coffee. For those of you that want to stay on, that's absolutely fine. We can have a little bit of a back chat. You can talk between yourselves about how's it going at your various sites, and in about 3 to 5 minutes time, I'll start the next presentation, which is a pre-recorded session I have about eating disorders, which is been presented by one of our Sussex eating disorder consultants. So I think that's very useful, since feeding disorders normally gets a lot of registrars a little bit twitchy about what to do. Okay, Mark, thanks very much with that, and all the best. I'll catch up with you later, but thank you so much for that. Okay, I'm just going to stop the recording for now.